Well, good morning, everyone. I'm Dr. Jim Allen, and I'll be moderating today's COVID health and wellness briefing. The purpose of these briefings is to give members of the media direct access to some of the COVID-19 experts here at The Ohio State University in order to help support and enhance statewide communications efforts about science and medical information. Let me introduce today's panel. Dr. Andrew Thomas is the Chief Clinical Officer for the OSU Wexner Medical Center, as well as the Regional Representative on Pandemic Response. Dr. Avraham Cooper is a pulmonary and critical care specialist at The Ohio State University. And Bob Weber is the Director of Pharmacy Services at the OSU Wexner Medical Center and also the Assistant Dean and Professor at the College of Pharmacy. Let's start with the first opening question to Dr. Thomas. Ohio has been battling this pandemic now for about 9 months, and a lot has changed in how we attack it. Can you give us an update?
Yes, thanks, Jim, for the question. And first, let me thank all those members of the media that are here today and dedicating your time and your efforts to try and educate the public on this. But Jim, in terms of the answer to your question, I think it's just always important to remember that we've just met this virus. It's been really less than a year for scientists, for physicians, for public health professionals to really understand the best ways to work with this virus and to understand it. When you think back to all the things that have changed, we didn't know really much about how it spread or how that spread could be prevented a year ago. Things like face masking, social distancing were not topics you heard routinely discussed this time last year. Certainly now we have a vaccine that's on the horizon with a new technology and a new vaccine that didn't exist at this time a year ago. How it's diagnosed is something that's changed significantly in terms of the type of tests that we have at our fingertips, the turnaround time for those tests. We've done millions of those just in Ohio over the past 9 months, and those didn't exist this time a year ago. We've learned a lot about how to treat patients, both in terms of those who are at high risk for severe disease to try and keep them from getting sick, but also for those who unfortunately do get sick and need to be in the hospital, whether it's new medications that, once again, we didn't have in our set of tools just a year ago, or new modes of how we deliver oxygen that we weren't using nearly as often as we are today. We've learned just a lot about how to treat patients. And lastly, I'd say one of the key pieces that's new is how we've organized ourselves as structurally or systemically to combat this pandemic, whether that's at the state level, at the regional level, or just here locally, where we have individuals and organizations that didn't even know each other a year ago, or in some cases were actually competitors with each other, that now are collaborating in a way that's just wonderful to see. So I think so much has changed in all four of those areas. How you actually catch it and how you prevent the transmission of the virus, how we diagnose it, how we treat it, and then how we've organized ourselves to fight the pandemic.
Well, Dr. Thomas, can you update us on the current situation as far as cases and hospital capacity in Central Ohio?
Certainly, Jim, I'd be happy to. In the state, we're sitting today at just under 5,000 COVID patients that are in the hospital across the state. That's about 1 in 4 patients that are in the hospital for any reason have COVID. In terms of ICUs, it's closer to 1 in 3, or just over 30% of all the patients in an ICU in Ohio for any reason have COVID. In the case of ventilators, it's actually in the last few days headed over 40% of all the individuals in the state that are on a ventilator. So heading closer to 1 out of every 2 patients that are on a ventilator in the state are there with COVID. In terms of more locally or regionally, the zone structure that the state has implemented has Zone 1 in the northern part of the state. Zone 2, which we are in, includes all the central Ohio counties, and then kind of everything down 23 south, 33 south, and 70 east. It's 36 counties with over 40 hospitals and health systems throughout those counties. And then Zone 3 is in southwestern part of the state, the Dayton, Cincinnati metro areas, and those corresponding counties. But in our zone, in Zone 2, back on November 2nd, we crossed 400 patients for the first time in the zone. Back in the spring, we peaked in the mid 300s. So that was interesting to cross that barrier of 400 on November 2nd. Just 1 month ago today, we were at 565. Today, we're at 1,204. So nearly triple where we were just on November 1st. And if you look back just a month ago, 113% increase in patients in the hospital. Here at Ohio State, we're just under 200 patients across our health system. in the hospital with COVID. And what we're seeing is a lot of activity every day with new admissions and new discharges. As we'll talk about in a second, we've cut the length of stay from a median of about 10 days to a median of about 7 days because of these new treatments. And that's benefited us by reducing that hospital census by being able to safely get patients home sooner. Across the zone, I think our biggest concern still is around ICU beds. Most hospitals and most communities in our zone have been able to expand the number of beds that they have or move things around so they could expand for kind of more typical medical surgical beds. But most hospitals are limited either in terms of space or specially trained staff in expanding their ICU capacity markedly. So I think across the zone, we have a number of hospitals that are limiting surgeries and procedures because those are patients that are more likely that are going to need an ICU bed. And they're really working day by day with their surgeons and their procedural teams to determine what they can actually do the following day or the next day in terms of surgeries and procedures. So ICU beds are by far, I think, our biggest concern at this point.
Well, thanks, Dr. Thomas. Question to Dr. Cooper. What's changed in how we treat patients now versus at the beginning of the pandemic?
Thanks, Dr. Allen. So now we, as compared to the spring, we've really developed a detailed knowledge of how best to approach the virus. And obviously we're still learning and new trials are coming out all the time. But across the spectrum of severity of illness of COVID-19, we have therapies that we can offer patients to help them recover. From the most severe patients who I take care of in the intensive care unit, those patients we're treating with steroids, which have been shown to reduce the severity of illness and decrease the mortality of the disease as well. We also have remdesivir, which has shown positive, which is an antiviral medication, which has shown positive effects on outcomes of patients with COVID-19. And then also the way that we can support patients, like Dr. Thomas said, in the intensive care unit, we've gotten better and better at keeping patients off the ventilator and being able to support them with higher levels of oxygen therapy while their lungs and their bodies heal. And in terms of patients with less severe illness, but still have symptoms and are at higher risk for needing to come to the hospital and developing more severe symptoms, we now are able to offer monoclonal antibody therapy. Bamlanivimab is what we're offering at Ohio State to those patients, which has shown some promising results in terms of reducing the progression to more severe symptoms and needing hospitalization. So really across the spectrum of severity of illness of COVID-19, we have therapies to offer patients.
What about in the outpatient setting? If a person gets COVID at home, what should they be taking in order to get through their illness, and what should they watch for in terms of signs that would tell them they need to get into the hospital?
Probably the most important thing is to stay in contact with one's primary care provider to make them aware of the diagnosis and then also how they are doing symptom-wise. In terms of monitoring at home, the main things to watch out for are severe shortness of breath, feeling like you can't do the things around the house that you normally would do because your breath just won't let you. That could be a sign that there may be that COVID may be affecting the lungs in a more severe way, and that would probably require hospitalization. Another way to monitor symptoms is actually to get a home oxygen monitor that you can put on your finger, and lower levels of oxygen on that monitor also, again, could suggest the need to go to the hospital. In terms of kind of self-treatment at home, it's really, for patients with mild symptoms, it's really no different than any other viral infection in terms of cough and cold medicines, staying hydrated, and taking medications like Tylenol to reduce fever. That's really the way to do it.
And the last opening comment is going to go to Bob Weber. Vaccines are really the hot topic right now. Can you explain what we know at this point about the available vaccines and getting the first healthcare workers vaccinated?
And thank you, Dr. Allen. Hi, everyone. So I've been a pharmacist for a very long time, and I've been giving shots for the last 15 years, vaccines. And we all know that vaccines save lives. And I'm very confident that there's a high potential that this vaccine could save many lives. Obviously, the FDA is meeting tomorrow So there's some information that we know and some information that we don't know. What we do know is that we have complete confidence in the clinical trial data. The 95% of COVID effectiveness prevention is very positive, and we're very, very, very encouraged by that. We also know that these vaccines are relatively safe. We know that minor things occur, obviously fever, things like muscle pain, et cetera, injection site pain as well occur, but they are very mild and moderate. We have received 975 doses of the vaccine, and we will be administering the vaccine to our healthcare workers who are at highest risk of getting COVID. Patients are, obviously, folks that work in our ICUs and other areas of the hospital that they are at risk for getting COVID. We have 3 sites where we're going to be giving the vaccine, and we have all of the necessary storage available. We have the safety measures in place as well for giving the vaccine. We are very encouraged by the data. We're very much looking forward to what the FDA says tomorrow. And this is really a very historic time in healthcare. Again, having the ability to use a vaccine to potentially save lives is very, very encouraging. Thank you.
Well, thanks. We're next going to go to questions from our media representatives. And I'd like to remind all of you, if you use the raise your hand function, I'll call on each of you individually and have you unmute yourself. For those of you who are calling in from a phone and don't have the ability to do that, I will be taking some time at the end to ask for questions from people who are just on their phone. We're going to first go to Pete Grieve with a question. If you could unmute yourself.
Yeah, I wanted to ask Dr. Cooper or Dr. Weaver about that monoclonal antibody treatment with the limited supply of it, because this is something that's for people who are not hospitalized. Can you speak to how Ohio is determining who gets those limited doses of that treatment?
Avi, I can take that one. So I'm actually part of the team as one of the zone leads that works with ODH on that allocation. What ODH is doing, because they get the allocation from the federal government each week of how much Ohio will get in total for their supply, and then the Ohio Department of Health works with the Ohio Hospital Association to look at case volumes around the state to try and determine which hospitals might have the most need for the medication. And then they allocate that proportionally to hospitals based on the COVID activity that's at that facility. So many hospitals around the state have decided to go ahead and take an allocation. It's obviously each hospital has a decision to make on whether they want an allocation or not. And then each hospital is approaching it slightly differently in terms of where they are providing the medication. In our case, we're doing it at East Hospital and what's previously was an auditorium that we converted over the course of about a week into an infusion suite. Some other hospitals are using procedural space that was empty at the time. Some are also using their home health services to have actually home health nurses deliver the infusion to a patient in their home. So it really varies hospital by hospital in terms of how they are then taking that medication and using it in their facility.
We're next going to go to WCMH News.
Yes, this is Matthew Herchuk with Channel 4. Dr. Weber, I have a couple of quick questions regarding the vaccine. First off, yesterday the UK began administering the Pfizer vaccine. They talked about some adverse reactions for people that are typically have allergic reactions or a high number of allergic reactions. I guess, can you talk about maybe that aspect of it? And then second of all, Dr. Fauci had made a comment about how people that have been infected with COVID-19 should still get the vaccine. I know that's a big question for a lot of people that have either had it and not sure how long that immunity lasts, or if they currently have it. Can you touch on that as well, please?
Yeah, I can just comment. So in terms of the adverse reactions, I did see that data this morning. I can tell you that there's a lot that we need to learn about that. I don't think the data is really clear as to, what we should do. I think we need to wait for the FDA's ruling on that. We need to look at the EUA. We need to vet that more. Obviously, it's a concern, but I don't know that there's any good answer. And I hate to tell you that. I just don't think there's a good answer for that. I think that obviously it happened, and we just need to understand it. We need to monitor that when our patients are being treated with the vaccine. And we do have systems in place to make sure that we catch those types of reactions, and certainly we'll be on the lookout for that reaction as well. In terms of folks that have had COVID and getting vaccine, there's also data that's not clear on that as well, but maybe Dr. Cooper can comment. But there's also not clear guidance on that from the FDA, and we're really waiting on that as well. It does make sense what Dr. Fauci says, but I don't think there's any clear statement on that as well. Dr. Cooper, do you have a thought about that?
Yeah, I agree. I think we have to wait for guidance from the FDA when we see the EUA come out, and how to approach patients who have had COVID, and also some of the potential adverse reactions that you mentioned.
It's important.
Yeah, Bob, I think one of the other key points that you referenced was whether it's our own staff who are in the kind of first round of being vaccinated, or once this gets to the general public, people need to expect that they're going to be asked to stay at the site where they receive their vaccine for a period of time to monitor for any sort of allergic reaction, and people need to build that into their schedule so that they're not looking to kind of get the shot and hit their car and be gone. They really need to plan to stay, and part of what we're going to use that time for is to educate them about what to look for as side effects, but also to schedule their second vaccine dose, because that's going to be a really important part of making sure people come back for that second dose, depending on which vaccine you take, either 21 or 28 days. So we'll put that time to good use, but people need to understand that's why we're asking you to stay.
Yes, because most reactions will occur within 15 to 30 minute time period that are serious reactions.
Well, thanks all of you. We're next going to go to Brittany Bailey.
Hey, good afternoon, or I guess still good morning, excuse me. I wanted to ask a little bit more about the vaccines as well. You kind of touched on that. I wanted to ask if there is concern about people getting the first round and then not coming back for the second, and how much of a concern that is, and how you do encourage people to do it. And I haven't read much about if it just makes it completely ineffective if you don't get that second round. But also I wanted to ask about the importance of continuing to do the other measures that we have been advised to do, such as social distancing and mask wearing. I've been hearing a lot that the vaccine is not going to be the end all be all, and we can't just suddenly think that we're going to go back to normal. And I'm sorry, since I have a chance, I kind of a third question as well. And it was about, oh gosh, I lost it now. I might have to come back to that one. I'll let you get started on that, sorry.
So I would say that the clinical trial data suggests getting both vaccines. So I would recommend that, obviously. There was some information in the FDA document that was released yesterday that said that there was some protection with one dose, but again, I would not recommend that at all. I would recommend getting the dose and then scheduling it for 21 days later. And I'm sorry, I forgot your second question. Oh, about the masking. I'll defer to Dr. Thomas.
Yeah,
Dr. Cooper.
That's a great question. I get a lot from my own patients. I think that it's going to be critically important for people to maintain those public health interventions until such time as we reach that herd immunity goal of 80% of the people, 70, 80% of the people vaccinated and immune, for a couple reasons. One, I think, is the psychological reason. Unless you're going to get a tattoo on your forehead that says I've been vaccinated, people don't know whether you're just not wearing a mask because you're being irresponsible versus wearing a mask, not wearing a mask because you've been vaccinated. But I think really it's the group approach to this, where everyone is committed to protecting each other and protecting themselves, is really going to be imperative. People just stop wearing masks when they've been vaccinated. But I think the reality is that this vaccine, like many vaccines, may not prevent you completely from getting the virus. It may prevent you from getting severely ill with the virus. I think, until we see larger numbers of people vaccinated, we aren't going to know for sure. But the last thing we want is people thinking that they are completely protected from the virus. It's similar to what we've seen with people who've had the infection and then gotten a documented second infection, a number of weeks or months later. we think that individuals still could become infected, still be spreading the virus to others, even if they've been vaccinated. So the science is still not really clear on that. I think once we see tens or hundreds of thousands or more people be vaccinated, we'll continue to learn more. It definitely reduces the risk of getting the infection, but it may not reduce it to zero. So until we know that enough of the society is protected, at some point, the CDC will direct us that we can stop wearing masks, but it's not going to be just when you get the needle in your arm.
Sorry, that actually reminded me of the other question, and you touched on that. I've been reading that while we do believe it offers, a certain amount of protection for the person who gets the vaccine, there's not enough evidence to show that you absolutely can't continue to still spread it somehow. Is that what you guys are hearing too, that you might be someone who's getting the vaccine, but you could still somehow be spreading it, or we don't know what that sort of level of protection will be, and that's another reason to not sort of back down on?
Correct. I'm not sure we know the exact answer to that question in a really widespread set of data. When you look at the people that have gotten the vaccine, first of all, it was tested for safety, right? Then it was tested to make sure that people were developing the antibodies that we hope that they got. And then I think they've looked as best they can over the last few months for people in the trials about what's the incidence of whether you get the illness or not. But I think in terms of if you do get a more mild case of the illness and then are you actually contagious, I don't think the answer is clear yet that you are or you aren't. So I think we need to err on the side of that you are contagious or at risk of being contagious if you do get the infection until we show or can show that the science proves that you're not. But I think everything I've learned from our infectious disease experts is you're still going to be at risk, even though it's much lower risk. And certainly much, much lower risk of getting severe disease than without being vaccinated. Bobby, does that make sense from your perspective?
Yes, thank you so much for indulging all of those questions. I appreciate it.
No problem.
We had a question from Jordan Laird.
Yeah, thank you so much for indulging all of those questions. I appreciate it.
Hi, Jordan with the Dayton Daily News. I think you might have answered it. Just the biggest question I've been getting from readers is, what is this vaccine actually designed to do? Is it actually designed to prevent severe COVID or spreading it? But I think you started to get at that, Dr. Thomas, with answering Brittany's question. Do you want to clarify any more on that? Like what does getting the vaccine actually do? How does it help?
I don't know, Bob, if you want to comment from the pharmacy perspective.
Yeah, the FDA basically
document.
says that it essentially builds immunity to the COVID virus through a messenger RNA system. And over time, obviously, as more folks are vaccinated, hopefully the spread of the virus will decrease. But essentially, it's really new technology. And part of the question we need to answer is, how does this new technology either cause adverse reactions with the vaccine, and how can we manage those? So that's the data we need to monitor, and that's really what we need the FDA's guidance on.
Okay, let's next go to Pete Grieve again.
So in the spring, hospitals took a hit financially when elective surgeries were sort of halted across the board. I'm wondering if you can talk about the current situation at Wexner with regard to elective procedures, and with nurses in the state saying they're sort of having to triage patients more carefully. Can residents of Ohio, whether they're COVID patients or non-COVID patients, sort of have assurance or feel confident that if they go to the hospital today or next week or in 2 weeks from now, they'll be able to get the care they need in a timely fashion? Or do more elective procedures need to be postponed, including those at Wexner, to continue, making sure there's resources for all Ohioans to get the care they need if they need to end up in the hospital?
Pete, thank you for the question. So first, in terms of what we're doing here, we have moved and shifted some of our locations for procedures away from the hospital to ambulatory surgery sites or to our East Hospital to try and free up some staff to continue with our routine operations. We are on a day-by-day basis looking at our capacity, our volumes, and our need for any further changes with whether it's a surgery or whether it's an outpatient procedure like a colonoscopy or a heart cath or anything like that. At this point, we've not needed to make major changes to those schedules beyond moving some of the locations around. I think as we've talked across the state, this time around, unlike where we were back in the spring, when the real driver of those changes was personal protective equipment and the lack thereof, because our supply chain was hit because a lot of our supply chain for PPE came from China. A lot of the reason that we stopped doing those procedures was PPE need. Plus, at the time, we didn't really have an understanding of what the virus was going to do to our hospital capacity. Obviously, we brought those surgeries back on through May and into June. At this point, the state has decided not to make any sort of a mandate, but to allow each hospital to determine its best course moving forward. So there's a lot of collaboration on our morning 9 a.m. calls, for example, in our zone, where each hospital reports out what's their total COVID volume, how many in their ICU, how many are on the ventilator, and then whether they're doing day by day or other limitations more in a blanket way for procedures. So we've worked pretty hard in our zone to move patients between hospitals to try and load balance to allow hospitals to maintain their normal operations as much as possible. But that decision has really been up to each hospital on an individualized basis. On our case here, we've actually been able to open about 80 additional beds in the past 3 weeks between our East Campus and our main campus hospitals that we think has really helped us a lot in terms of managing that capacity of patients, and has helped us to maintain more of our normal operations than some others have been able to. So I can't remember, I think there was a second part to your question.
I guess I'm just wondering if you think it's on the table in the coming weeks for more changes to come. We've seen states like Massachusetts do a statewide halt on elective surgeries.
At this point, I'm not aware. At this point, I'm not aware of any plans from the state of Ohio to mandate anything with that regard. I think each region of the state has a slightly different version of this pandemic, and each hospital has a slightly different set of resources and capabilities. So I think it's a little bit hard to create a one-size-fits-all policy that would be a blanket for the whole state. But our hope is that if the public listens to the advice from their doctor, the advice from their local hospital or local public health officials, certainly, as you all know, we've been from the governor's press conferences and other things trying to get out our best messaging around masking, keeping your distance, staying inside your bubble, washing your hands routinely when you're out in public, and really trying to only go out for kind of essential things that you need to do. We hope that we can bend that curve to the point where we level off and then start to go down in terms of the need for patients to be in the hospital. I think the risk we have coming out of Thanksgiving from a hospitalization perspective, we haven't quite seen that happen yet. We would expect it's somewhere 10 to 14 days after the holiday weekend, and that's kind of where we're at now. We would start to see numbers go up if they're going to go up. But we think if the citizens of Ohio listen to all those best practices, do their best to stay in their bubble and reduce their own risk of getting sick, that just trickles down. Eventually, it has a real positive benefit in terms of avoiding hospitalizations. And I can't also emphasize enough the monoclonal antibody treatment that Dr. Cooper talked about in terms of those highest risk patients and reducing their risk of being admitted to the hospital. So that's something that a lot of hospitals around the state are utilizing, and we hope that also reduces our number of patients that need admitted.
We had another question from WCMH News.
Yeah, doctors, I think it was Dr. Thomas, you talked about the state of ICUs, and I just wanted to touch on that more specifically. Earlier in the week, I did a story, and there was only 187 ICU beds available in all of Region 4, which is Franklin County and 14 others, which seems like a reasonably small number given the number of ICU admissions that we're seeing daily. At what point do the hospitals make a decision to enact some of their contingency plans to open up more ICU beds before it gets to a critical state? And then I guess the second part of that is we are seeing more people enter hospitals, and we're seeing more people that are get severely and critically ill. Can you talk about that in relation to the therapies that are available? And, is the virus evolving to the point where maybe it's changing? Can you talk about why more people are getting sicker than they maybe were before?
I'll take the first part. I may have Dr. Cooper take the second part of that question. In terms of how other hospitals make their decisions, I can't really speak to that. I can tell you what our strategy has been. And that's been when we started to see the numbers go up in October in terms of the patients we were either getting in transfer or patients who were being admitted through our emergency departments within the Wexner Medical Center system. We have taken a tact of kind of keeping ahead of the curve. So we have a number of obviously pieces of data we look at every day. We look at the rise in patients over the last 2 weeks and project forward. If that rise were worse than we've seen the last 2 weeks, consistent or better, where would our need for the COVID census go over the next really about 6 weeks? And then we try to make sure that we have interventions in place to grow capacity to try and meet that need, even down to the individual type of bed. So for example, today we're opening 6 new ICU beds here on our main campus, and we have 3 additional beds on that unit that we plan to open in the next week. There are 6 additional ICU beds at East that we can convert from progressive care to ICU status over the next week if, to once again, stay ahead of that wave of data. So that's been our approach and why we felt comfortable each time. If we have a way to increase our capacity, then we may not need to make some of those more difficult decisions on limiting certain types of procedures. But obviously at some point you reach a maximum, either from a physical bed space perspective or frankly from a staff perspective, that we need to repurpose that staff from a surgical unit or from a procedural unit to do other things and take care of inpatients. So that's how we've approached it. And I can't speak for how other hospitals have approached it. But Dr. Cooper, would you like to cover the ways we're keeping people out of the hospital?
Yeah, so the number of patients who develop severe symptoms and manifestations of COVID-19 who require hospitalization or transfer to the intensive care unit is really driven by the number of patients who get infected with the virus. And so if more patients get infected with the virus, there's a certain percentage of them that are going to need to be hospitalized and a certain smaller percentage that will need critical care support. And so that's why those public health measures that Dr. Thomas was referencing are so important. Why for appropriate patients, monoclonal antibody therapy is helpful as well. But we do know, like Dr. Thomas had said, that the patients who are coming into the hospital are staying less long in the hospital. They're ending up on the ventilator if they do less, they're less often on the ventilator and spending less time on the ventilator, and frankly, passing away less often from the virus. The mortality has gone down, and so that's that's really a reflection of the therapies that we can offer and the supportive care that we can do. But I think it's really, the total numbers are really driven by how many people get infected.
We're going to take one last question from Pete Grieve.
Yeah, just quickly, hoping to get a little bit of clarity on the vaccine plan in terms of those 9,750 doses that are going to hospitals. Governor DeWine seemed to indicate that maybe, well, obviously most of those doses are going to be for hospital workers, healthcare workers. Is there anyone else getting those doses, people who don't work in a hospital but maybe have some sort of interactions with COVID-19 patients that puts them at very high risk?
So I'll take a crack at that. I've not been as directly involved in that process with the state, but the 9,750 doses is what they're calling pre-positioned doses. Those are doses that are going to 10 hospitals around the state. And that number is kind of an odd number, but it's driven by the way Pfizer packs the vaccine into boxes of 975. And they're pre-positioning 10 of those boxes at 10 hospitals around the state. We happen to be one of them. So that as soon as the EUA is approved, we can, as quickly as possible, start vaccinating our healthcare workers. But there are other sets of vaccine that are going to be shared with pharmacy distributors. So CVS and Walgreens are the ones that I hear about, but I know there are multiple others that are going to be working with nursing homes, both in terms of the residents who are in the nursing facility, as well as the staff. And then local health departments are also going to be receiving vaccine, and those are mainly geared towards EMS workers and first responders. So it's really the 9,750 is just one part of this first set of allocations. And then really, I think, I don't know, Bob, what you think, but from every call that I'm on, ODH seems to know more than it did the day before or the week before in terms of the cadence of future deliveries, in terms of which vaccine it will be and how many, and then how many will be put into each kind of flow of vaccine?
I would predict that we'll get much more vaccine sooner. Obviously, the Moderna product will be approved as well, and so we'll get that as well, Dr. Thomas. So my hope is that we will get a steady flow of vaccine that can vaccinate our healthcare workers first, and then obviously focus on our patients second. So I'm optimistic from what I hear.
So those 975 doses that you're getting, those will go to Ohio State.
Yes.
Nurses and doctors, but also other hospitals nearby that may not be a distributor of at first.
So that, once again, Pete, those are just the pre-positioned doses. I believe the number is over 110 hospitals around the state that have signed up to be a vaccine distribution location. So those hospitals will also be receiving vaccine from the state, from the federal government through the state process on an allocation model, similar to the way we've done other medications over time.
Well, let me thank today's panelists, physicians, Dr. Andrew Thomas and Dr. Avraham Cooper, as well as pharmacist Bob Weber. And I'd also like to thank each of you from the local media for the role that you're playing in keeping the people of Central Ohio up to date on the COVID-19 pandemic. We'll be back next week to talk more about the latest news on COVID-19. Until then, stay safe, wash your hands, and wear a mask.